A study showed that women account for 60% of stroke deaths in the US. Yet, and I believe as a direct cause of the majority of studies done in cardiovascular disease, was done on men, the avatar of the 70 kilogram, white male. And many of these studies border on the ridiculous. The major studies that have set the so-called gold standard in cardiovascular treatment, such as aspirin and statins, mostly done and some exclusively only on men. And that's just one powerful example of gender bias and negative impact on diagnosis. Gender bias shows up in every aspect of medicine. I mean, every aspect. I'm just giving you one quick example.
Gender bias, what is it and how does it affect your health? How does gender bias affect our healthcare system and your role in that healthcare system, and what can we do about it to make our system better? These are the essential questions we are going to be diving into today very deeply with Dr. Ben Gonzalez. I am Dr. Andrew Wong, co-founder of Capital Integrative Health. This is a podcast dedicated to transforming the consciousness around what it means to be healthy and understanding the root causes of both disease and wellness. And I would add that today's podcast is going to be focusing on how we can better the healthcare system itself. Ben Gonzalez is medical director of Atlantis Medical Wellness Center in Silver Spring, Maryland. He believes in the overall holistic approach to maintaining your health that includes proper nutrition, exercise, and well-being. He's also a board-certified physician with a background in molecular genetics and nutrition. And I would add that he's passionate about bringing gender bias to the forefront of conversations on how to optimize our healthcare system. Today, we're going to discuss a really important topic, how gender bias in research, diagnosis, and healthcare overall impacts the care that you receive and the treatment that you deserve. Welcome, Dr. Ben Gonzalez, to the podcast. Thank you so much for coming on today.
My pleasure.
Yeah, so we've known each other for a while now, and we've talked a lot about integrative health, hormones, functional medicine, just kind of informally over the years. But recently, we were talking about some other topics that have come up, one of which is really, really important that we haven't covered on this podcast yet that I really want to dive into today, and you're an expert on this, called gender bias. So first of all, let's talk about what that is and why that's so important in medicine and health.
Well, sure. And in fact, when I give these discussions, I start out with this story that kind of accelerated what I already knew, the underlying issues with all of this whole subject on gender bias. But it was 16 years ago when I opened up my clinic. I had just retired from the military, and I was doing some fun things at the time, as well as functional medicine, and some of the fun things I was doing was neurotoxins, Botox, things like that. And a patient, 42-year-old Sarah, came to me to see me for Botox, simple Botox. And I did the usual Dr. Gonzalez thing, told her, asked her the basic questions and the allergies. And then in the end, the intro, I said, "So how are you feeling?" That one question, she literally just broke down in tears, just the you can't speak, sobbing. And when I thought I thought I had offended her in some way, or I said something that obviously triggered her. And then when she got her voice back, she goes, "I feel miserable. I'm 42 years old. I'm overweight. I exercise an hour a day." She was telling me this story about how she loves her husband, but she has no desire for sex. She just went on and on. And she said, the worst part was this morning. She went to right before she saw me, she had gone to her GYN doctor for her annual. And she told the same story to her doctor about how she was feeling. I can't lose weight. She hardly eats anything. She has 3 children she loves. She's trying to keep up and can't. And she feels so tired. She told this to her GYN doctor, and she looked at me and she said, and my GYN doctor looked at me and said, "Honey, that's how you're supposed to feel."
Oh, no.
42 years old. She has at least 40 more years of viable life, 3 children to raise. And this is how you're supposed to feel for the rest of your life. And this the worst part is this was a young female GYN specialist. And so, Sarah wasn't coming there to see, by the way, she's still my patient 16 years later. She wasn't there to see me for Botox. She was there for anything, for something that would make her feel better about herself. She tried the system. She tried, she exercised. She did all these different diets, everything. And all she wanted was something to make herself feel better. And that's just one. And I hear that story every week, every single week. So when I talk about gender bias in medicine, we usually either mean an unintended but systemic or systematic neglect of either women or men. It's not just women, but either women or men, but in particular, mostly women. Stereotypes, like, they're assumed, and assumed gold standards are based on studies, mostly on men, with the idea that women are smaller men. And this started far back, way back. Way back when Aristotle called women inside out men. I don't know if you know that, but he called women inside out men. He defined women as medically faulty and defective. And this idea of women being the defective sex was perpetuated over centuries, magnified early in the 1900s. I don't know if you know this or not, but our current U.S. Education system was overhauled right around 1920. The Canadian and U.S. Medical education system was overhauled, for better or for worse. And in the context of women's health, it was for the worse, because this is where the modern gender bias began. First in the overhaul was to eliminate women as physicians, period. Eliminate
You're
women
talking
as
about the
physicians.
Flexner report, Ben?
Yeah, the Flexner report, exactly.
I didn't know that actually. That's crazy, though. That doesn't. What was the justification for that?
Oh, well, it was to standardize, the idea of standardizing what was all over the place at that time. It was good medicine happening, but there was also just junk. And so they wanted to standardize, but he based this on a German concept of tying the medical school to a hospital, which was a good thing. There was a lot of good things about this. But unfortunately, like I said, one of the first things they did was to eliminate all female physicians. And then the second thing was to standardize the idea of focusing on diseases only in medical education, not in health. So of course, this is a bit more complex than that, but in short, that like gender bias is the systemic neglect of women in our healthcare system.
Wow. There's so much profundity there. And women being, at least half of the world's population, that doesn't make a lot of sense to not have women's physicians, right?
Yeah. It's at that time, the average lifespan of a woman was about 52 years old. And if you're a woman of color, it was around 38, 39 years old. So you fast forward 100 plus years, and now the average age of a woman is 82, and women of color are catching up about the same. But we in the healthcare system are stuck in the idea, all the studies, are stuck in the idea that women are done at the age of 52. You're done. And so we throw Prozac at you for your menopause symptoms, thinking that's going to fix your health for the next 40, 50 years. We tell the 42-year-old struggling mom of three that this is how you're supposed to feel. Yeah, it's rough.
And I know you're also, certified in fellowships and sort of anti-aging medicine or healthy aging. And in a way, when I hear you speak about this, your patient Sarah, that's 42 years old, even I think our language is kind of like, why don't we call it 42 years young? She has half of her life left, We're almost like age bias too, right? Like you said, 52
Yes.
years, we're done, menopause, we're done. That doesn't, but, there's still like 30, 40, maybe more years to go for a lot of women, based on their life
Viable years.
Yeah.
Not just we're going to get you to 82 in the last 10 years of your life, you're in a cane or a wheelchair. No, we're talking in order to get to maintain or get to that point of viable end of life years, you have to start early, and the gender bias neglects that.
Would you say that's why integrative health, which we both practice, of course, is becoming more popular now among the mainstream? Getting to more like, let's look at, both genders or all types of genders. Would say transgender, gender neutral. Also focusing on both not only disease but also wellness. What are your thoughts about the role of the integrative health movement and gender bias?
And I want to start off with a negative thought, but I am hopefully
Let's
end on a
go there. Let's
positive,
go there first, so
and
we can
hopefully end
always
on a
go up.
positive. Yeah. So I went to the University of Arizona for medical school, studied under the auspices of a guy named Dr. Andrew Weil. A lot of integrative physicians know Andy and know of his work. He's still out there. 30 years ago, these were the narratives that we were talking about. Whole foods, organic, eat better, think about prevention of disease. The exact same narrative that we have now. Yet we haven't gone anywhere. I feel like I'm still lecturing, preaching to the choir. I'm still, the, the world has got, the U.S., the world has gotten fatter. We're supposed to be, that we're supposed to be in a better place because of what we were thinking at the time. That same exact narrative is happening today. So it's very frustrating. We are stuck. We in medicine, and this is how we're trained. We're trained to think linearly, and we're trained for at least gold standard, so to speak. We're stuck, and it's hard to change that. Um, and uh, the good news is we're still talking about it. Now we have more standards. We have integrative medicine groups. We have integrative medicine discussions that are trying to standardize this. And hopefully we'll move ahead a little faster in the next 3 years, let alone 30 years.
Well, let's talk about, thank you. Let's talk about how gender bias impacts different aspects of health, whether it's things like
Yeah.
clinical trials, whether it's treatment in the exam room, whether it's patient outcomes, even lack of access to care or maybe even fear of going to receive care because of always being shut down. So let's just talk about all those things, explore
Can you
these things.
imagine that? Can you imagine being shut down over and over and over? And I'm not talking about just for each appointment you've gone to, but for decades as a gender being shut down. Um, and it's frustrating. Probably probably the most common example is cardiovascular disease, right? The number one killer of women in this country is heart disease. It's funny when I ask my patients, both men and women, I ask them what's the number one killer in this country for women, and usually I get things like breast cancer and cardiovascular disease. That's getting more and more understood, but it still surprised me the high percentage of people that don't understand that number one killer of women is heart disease. And in fact, the absolute numbers for women living with and dying of cardiovascular disease and stroke exceed those of men. And in fact, about 10 years ago, a study showed that women account for 60% of stroke deaths in the US. Yet, and I believe as a direct cause of the majority of studies done in cardiovascular disease was done on men, the avatar of the 70 kilogram, white male. And many of these studies border on the ridiculous. The major studies that have set the so-called gold standard in cardiovascular treatment, such as aspirin and statins, mostly done and some exclusively only on men. And that's just one powerful example of gender bias and negative impact on diagnosis. Gender bias shows up in every aspect of medicine. I mean, every aspect. I'm just giving you one quick example.
It reminds me of, I don't know if you know Dr. Alyssa Zingman. She's in Silver Spring. She's a musculoskeletal specialist, has EDS. She's been on the podcast talking about EDS. She was sharing with
Yeah.
us that in her, 10, 15-year journey of trying to get a diagnosis of EDS, as a physician, she was shut down multiple times by many doctors saying she's a hypochondriac. They knew she was a doctor, so I thought that was really, and I would almost wonder, like, what if she was a guy, or what if I wonder if they would have taken her more seriously. I don't
And
know.
that's been studied.
Yeah.
That's been looked at. I mean, over the last century, since that overhaul of our medical education system we talked about earlier, basically women's health is boiled down to breasts and pelvis. I mean, if you Google women's health, you'll find the top discussions concern breast, ovarian, and uterine cancer, sprinkled with sexually transmitted diseases and weight loss, and all followed by discussions on abuse. In other words, mostly victim medicine. And that's kind of where it's been worse. If you go, this drives me nuts now I think about it. When you go to the CDC Women's Health section, the CDC Women's Health section, and you go to the cardiovascular disease and women's health landing pages. And I just checked it this morning, wondering if it was still this way. But those sections have been missing links and landing pages for years. And like I said, I just checked on this morning just to make sure that's still, yep, and it's true. Yes, basically women's health has been boiled down over the years to what's called, what was termed, I can't remember who did it or when I first heard this, but bikini health.
So they
Women's
literally
breasts
have a
and belly.
broken link on the number one killer in the US for the women's health, which is cardiovascular disease. Well, let's just do a PSA because I think that is sad, but let's try to be part of the solution here. What is the number one or number two, let's say, what are your top symptoms that you would see for women if they have heart disease symptoms? Because we know that it's a little different than men, right? It's not always that classic angina or chest pain. It could be, but
Well, it's funny you should ask me that because I have a very personal story that, and I don't even know if you know the story. I don't know how you get that question in, but it's perfect for my wife, my very beautiful, in shape, vegetarian, highly active wife. You see her on TV. She does these TV things, and you see this very active um, Latina woman, great shape, vegetarian. She had her first heart attack at the age of 38.
whoa.
And all physicians know, heart disease doesn't start on the day that you had that heart attack. It started years before. And and so she had symptoms of just being a little tired, mostly GI symptoms, some pulmonary symptoms. And in fact, she'd seen some specialists for her GI issues and her pulmonary issues. She had some great doctors. And I'm not disparaging physicians. I'll make that really clear. I'm going to say that now. I'm not disparaging physicians. I'm frustrated with the system. So my wife, she goes to these docs, gets treated, gets tested, gets all sorts of tests and treat, but it can't be your heart, obviously, as you're 38 and you're vegetarian in great shape. All the way to the point where she had her heart attack. And that was when she was 38. I met her 4 years after that. And it surprised me that she was on 4 different cardiac drugs, caught me totally off guard. So kind of liked her when I first met her. And and so I put her through my full functional medicine workup, and lo and behold, there were some things missing, some base, and she had great physicians. In fact, her cardiologist was the president of the, her business is in DC. We live in the DC area. Her cardiologist was the president of the Women's Cardiology Association, the U.S. Women's Cardiology, American Cardiology Association. So she had great physicians. Now, when I did the workup, her vitamin D level was in single digits. I think it was 6. I checked it again, and it was single digits. Her testosterone levels were non-detectable at when I met her, 42, 43 years old, non-detectable. Do you think testosterone plays a role in heart function, cardiac function? Yeah, just a little bit. And that's one of the biases. And I know I'm going to probably deviate here if I start talking about hormones.
We can talk about that. Yeah,
women.
We'll go
Yeah,
down
we
that
can hit
rabbit
that
hole.
later.
Let's
That's
hit
a
that
big
later.
subject. That's a whole podcast. But
Yes.
but the bottom line is, and those are just a couple of things. Her magnesium levels, her red blood cell magnesium levels were low. There were multiple things. So over a period of 18 months, correcting those things. Remember, things don't happen overnight. We don't fix things overnight, right? It takes a little time. So over 18 months, corrected those things and was able to get her off of all her cardiac drugs. And by the way, she was told she needed to go on a 5th one, a beta blocker for heart remodeling, all that. And her blood pressure was in the 90s. So she just didn't want to go any more medications. So anyway, over 18 months, got her off all the medications. But don't get me wrong, this is not a discussion about, medicine bad. It redirected, looking at her as a woman, not as a man, not as the gold standards of cardiovascular disease, a 70 kilogram male, white male, but as a Latina woman and her physiology, correcting those things and putting her on the right medications to get her into the right place. And her last cardiac cath, ejection fraction was 46%. And her cardiologist said, "What are you doing here?" So, that's here's I could go on. Sorry,
This is
but
great.
here's what happened at her last cardiac catheter. I can't make this up. She's post cardiac cath. She had a little bit of a chest discomfort, so took her to the hospital, had cardiac cath, doing fine. Um, and during rounds, all the cardiology fellows, not the interns, but all the cardiology fellows came around, and they presented, they presented who she was to the attending, and then the fellow said, "And she's better because of all the cardiac drugs she's on."
Hmm.
Because in her chart, it still showed that she was on beta blockers, lisinopril, statins, etc. And she looked up and she said, I'm not on any of those drugs. I haven't been on it in a while." And then the fellow kind of muffled a little bit and then said, "Oh, well, you got better because of those drugs." And she goes, "No, no, I'm here's my list." And she gave him the supplements and the medications, the vitamin D, the testosterone, the hormones, all those things. And he was a little flabbergasted. And he said, "Well, you got better because of the drugs." He just kept persisting in saying that she got better because of the drugs, and she hadn't been on them in years. And she was a little better on the medication, but still having side effects. Imagine all the side effects.
Yeah.
Let alone, the other issues that these medications cause. And so the attending finally stepped in and said, "Wait, hold on, let's listen to her." And so the dogma of gold standard, so to speak, is ingrained in us. It's beaten us as physicians. And we're taught to think linearly in medicine. And that's the most dangerous way to think in medicine. In engineering and logistics and whatever, 1+1 is 2, but in medicine, 1+1 could be pie and chocolate, and we have to think away from the linear thought process that's beat into us in medical school and then driven hard in residency, and then more so in postgraduate education. We just have to get away from that. And my wife's a perfect example. Frankly, I got into this. So I'm a medical feminist, if you haven't figured that out by now. I'm
That's awesome.
100% medical feminist.
Uh-huh.
And every single thing that I learned was not from the books, wasn't from good old Dr. Weil. I mean, he pushed me, of course, but it was from the mistakes that I saw I made in medicine in the beginning of my career, the mistakes that I saw with my wife, with my sisters, with my mother, who suffered from obesity for years, who had a gastric bypass in the 70s. When I was in high school, had a gastric bypass in the 70s, and we were only doing 5,000 bypasses a year then. And then watching her over the decades after that suffer through the diets and the procedures and the torture that the system. And then when I became a physician, thinking I'm going to fix my mom, and then making the same mistakes because they were beat into me, knowing that there was something wrong inside. There's something just wrong underneath and what I was saying to my mother, my sisters, the women that were in front of me, even in trauma. And this is where my passion comes from for this. My family, my female patients, my wife, my daughters, my grandchildren, who this all starts early with the very first GYN exam. Starts early. So anyway, that's where my passion comes from.
Thank you for that personal story. And I think we can all agree that, women do make up the majority of quote unquote patients in the healthcare system. So we really do need to be more attuned to gender bias and really treating people like individuals, right? I want to get into really a little bit here on since we talk about women here, but also trans and gender neutral. What is your thoughts
Yeah.
about that? I'd love for you to educate our listeners on that a little bit.
Yeah. So gender bias obviously is, and I focus on women's health, so that's where my discussions come from. But yes, gender bias, the true definition involves whether it's men, transgender, or otherwise. And in fact, it was interesting for the very first time at a large conference last November. For the very first time, I heard lectures on the subject of transgender medicine in the context of integrative medicine. And I'm not talking about just 1 hour. I'm talking about there was a whole afternoon dedicated to transgender medicine, and it was fascinating. So gender bias, it's bad enough when we're talking about women in general. If you're a woman of color, it's worse. If you're an older woman of color, it's worse. If you're anywhere in the transgender community, it's probably the worst. There's no counseling. There's minimal studies. We're guessing. And as you know, I do hormones, and I help with transitions after counseling, after the appropriate counseling, and there's nothing. We're guessing. We're taking shots in the dark, and I see these patients come to me on high doses of hormones, and it was dumped in their system like in 1 day. No transition to the change, so there's in that context, we're way behind. So I was talking about a century being behind in women in general. Think of how much further behind we are with transgender medicine.
Got it. Well, this is a lot of eye-opening conversation. I hope this is something that we all think about as healthcare professionals, but also as the public. We need to kind of be the change and just be aware. Just being aware of these issues, I think, is the first step. Let's talk about some things, in terms of diagnoses. We'll talk about health as well. Let's talk about diagnoses first. So we think about certain, big topics. We talked about heart disease and the difference in symptoms between women and men. Even though we're educated as physicians, right? We're educated as practitioners that there's some symptom differences, but at the end of the day, if we're kind of like you said, the system kind of hammers into us. Well, a lot of times people are just making this up or something, or that's not really real symptoms. So even in the context of okay, let's take it seriously, the system is kind of subconsciously telling us not to take it seriously in a way. Unless we listen with open ears and open hearts. Overtly as well. Yeah, exactly. When mental health, so women are nearly twice as likely as men to have a mental health condition, but then also that's more likely to be used as a reason for their symptoms, whether it's mental symptoms, physical symptoms. What can we do, or how can we kind of change or transform as a healthcare system, as practitioners as well, in terms of treating all genders, better?
Well, first, I guess, is the understanding that it exists. First, acknowledging that gender bias exists, right? It's everywhere in medicine, everywhere. This is where I've spent most of my research on this subject. There's a timeline of neglect. To get to an understanding, there's a timeline of neglect to understand here for providers. And let's jump 50 years ahead of that Flexner report that we talked about earlier, the 1920s, 1915 Flexner report. Excuse me, that overhaul of the medical education. Let's jump 15 years ahead of that. So not much changed in that half century. In fact, very few women in the medical field, mostly men, were participants in medical studies. In the early 1970s, the percentage of female physicians were still in the single digits. It's crazy, isn't it?
Yeah.
I mean, still in the single digits, and that was in the 70s. I mean, even with Title IX in 1972, right? I think Title IX was 1972. The education amendments came Now go ahead 20 years from that time, so 1990, um, and only the OBGYN specialties finally break the 50% mark. But all the other specialties were still less than 15, 20% women. So jump ahead another 20 years. And in the hierarchy of medicine, deans, full professors, first authors, um, they all had a very low percentage of women. And in 2018, in a 2018 study, showed that narrative pretty much is the same. So did you know there was this is going to kill you. Um, did you know there was an actual policy, an actual FDA policy that excluded women from phase 1 and phase 2 drug trials, including contraceptives? Now, how do you, right?
Yeah,
How do
I can't even wrap my head around that,
how do
but
you
yeah.
reconcile that,
Yeah.
right?
Yeah.
It's so dis, and here's the justification. They're citing, and I'm quoting, I'm paraphrasing, I should say, um, the delicate nature of the fertile female as the reason we're not to include them in these trials. And I'm not making this up. In the late 1980s, there was a memo circulated in the NIH to encourage the inclusion of women and minorities in studies. We're encouraging. I mean, that's all it was just a memo. And it wasn't until after I was in medical school that the NIH turned that memo into a policy. And it wasn't even until after maybe during medical school, maybe after medical school, that Revitalization Act, what year was that? 90, early 90s, that policy was turned into law in the 90s. It's crazy. And it wasn't until after 2000, after the turn of this new century, that the Institute of Medicine actually recognized that women and men are different. And I'm not making this up.
Wow.
It's called the Sex Matters Report. I was giving this lecture, Dallas, and I was about 20 minutes into this lecture on gender bias. And I was giving these discussion, these introduction to the history of what was going on. And I was just right past the history. I was getting into the studies. And one of the physicians, she raised her hand, and they were told all the audience to bring their questions after we finished speaking. But she raised her hand. She kept putting her hand up. And finally, she stood up. I couldn't ignore her. She stood up, raised her hand, and I finished my slide thought. And then I pointed her and said, yes, what's up? And she says, she says, I don't believe you. She goes, I don't believe you. And heads were like they were just, the cognitive dissonance is so incredible that, she stood up and said, I just don't believe you. And I said, oh, give me another 20, 30 minutes. It's going to get worse. And I said, just don't throw tomatoes at me. It's the system. It's the system. And you guys are, the physicians are the victims in this system. But ultimately, of course, it's the patient that pays the price.
Wow.
So I get fired up about this. There's some really crazy examples. A study out of Rockefeller University Medical School looked at how obesity impacts breast and uterine cancer. I don't know if your audience knows this, but I know you know this. I specialize in metabolism medicine, weight loss and metabolism. And so I came across this study, and looking at obesity and how it impacts breast and uterine cancer, and all the subjects studied, all of them, 100%, were men. Let that sink in.
Yeah.
A study on how obesity impacts uterine and breast cancer, all done on men.
How can that even? Yeah, that.
How can that
just
pass
blows
the
my
IRB?
mind. Yeah.
Yeah. How can you imagine that IRB discussion? I would love to have sat down, go back in time and sat down in that discussion and just, how did that even get justified? And this isn't in the 1920s or 30s. And this isn't, this is not a university to throw dirt at. This is the Rockefeller University in New York City.
A very reputable institution. Yeah. And we're we're making our clinical decisions in the exam rooms with patients based on this data, right? So we need to shine a light on this, like you're doing so brilliantly here. Since you are a metabolism and healthy weight kind of doctor, this is a perfect segue into a question I was about to ask you about IF, intermittent fasting. What is your thought about IF and gender bias, right? Is IF good for everyone, right? I mean, if you think about some of those studies, if they've been done on mostly men, this is one of the questions I have about IF.
Yeah, it's funny you should mention that because in my lectures in obesity, when I talk about metabolism, medicine, obesity, hormones, there is a difference between men and women. We unlearn that in medical school. We do. It's ironic. We unlearn the difference between men and women in medical school, and then it gets even more beat into us, like I said earlier, in residency. But there's a difference in our physiology. There's and this goes from everything from reduced oxygen carrying capacity. There's actually in pharmacokinetics, the standard drug dosage is is based on that 70 kilogram male. Even in women, the ion channels react differently in renal and cardiac and cardio-specific medications differently between men and women, and we don't take that in consideration. Hormonal response. You were asking about intermittent fasting. There's not a lot of studies done on. Studies are poor. There's the paucity of studies when it comes to weight loss and weight loss management. Metabolism is low. We think there's a lot of studies out there, but most of the studies are done in a gender biased fashion, of course, done on weight loss, but not on metabolism and not on the management of metabolism and the maintenance of weight loss. So all these physiologic differences between men and women matter when it comes to what diets and exercise and intermittent fasting, as you mentioned, when you're giving that advice. Now, I know this discussion, this goes beyond the podcast, but I hope you don't mind if I mention a few things.
Of course.
That, like, for example, postprandial metabolism. Glucose and fat oxidation is different between men and women. Exogenous estrogens, for example, a lot of women on birth control, so if you're on exogenous estrogens, induce the reduction of postprandial free fatty acid oxidation. So translated, what that means is, if a woman's on a medication, especially if they're on a hormone, they're going to react differently. And women know this. Physicians know this. We ignore it. We see the changes in physiology when we give a medication to a woman as opposed to a man, but we kind of ignore it. We just blow it off, or worse, we give another medication for that side effect. Women burn more fat during exercise. There's a higher fat glucose burn rate, yet women have a hard time losing weight. Why is that? Well, we don't understand the full reason why that is. Women lose less fat than men with the same energy deficit. So to answer your question about intermittent fasting, is that there is a difference between how women and men react. Intermittent fasting does a body good overall for men and women, but we need to be careful of persistent ketones, a starvation state that's induced because a woman or a man stops eating as much and they start eating less and less and less. So what happens to their metabolism? Their metabolism adjusts and starts to slow down. And then you throw in intermittent fasting to someone who's not eating a lot in the first place. And you get a different reaction for men and women. You get a different result. And yet we give the same advice to both men and women. I hope I answered that.
Yeah, you did. Yeah, thank you, Ben. I think just throwing in, the adrenals, thyroid, and whole sex hormone axis, right? Intermittent fasting will affect all those in a different way too.
In a very different way.
Yeah.
And then if you're on a medication, especially if you're on a birth control, right? And we give the same advice. One of my complaints in my field is that we give the same advice to the 20-year-old, the 30-year-old, the 40-year-old, and the 50, 60, 70-year-old when it comes to exercise more, eat less. We don't adjust our discussion to that same height, same weight woman who's 25 versus when she's 55. All the different medications are on, whether they've had children or not. Every time a woman has a baby, they become a different woman, and we need to take that into consideration.
It's really about personalized medicine, it sounds like. What can we do to stop gender bias in the medical field? What are some of the solutions that you foresee here?
Right. Educate, right? I mean, educate. Now, my mistake, I shouldn't say mistake, my focus for years was to educate physicians, and of course the patient in front of you. But now I've changed my mind a little bit. I've decided to kind of go into okay, let's get the general public understanding this. And I'm not original on this. There are other great, and in the end, when we talk about resources, I'm going to give you some great, great individual physicians and entities that are doing their best to educate the general public. But I've shifted my discussion to physicians. I feel like I beat my head against the wall on this, to the general public. So I'm actually writing a book about this. I'm a little late with it. I've been talking about this for over 6 years. Very frustrating. But I'm writing a book on gender bias. And of course, a male physician writing a book on this. But you heard some of the stories I told already on this podcast. I think as women start to relate to what I say in the stories, that I think the general public will be more and more outraged about this. But we're behind, right? We talked about this. We're not just behind by a few years or a few decades. We're behind by a century, and we haven't even talked drugs and the craziness about drugs and FDA approval for medications for both men and women.
Well, let's touch on that for a sec before we get to resources. So
good. I'm glad. I kind of hinted there. I'm glad you took it.
Can take that, smell that hint there. Let's talk about FDA-approved drugs, and what percentage of those drugs that are approved are actually based on gender bias studies.
Another one of those. It's gonna just you can't understand, right? So the sex differences of 1/3 of all FDA-approved drugs are unknown. There was a 2005 analysis of 300 new drugs it showed substantial pharmacokinetic differences and with no labeled sex-specific dosages. So, around the turn of the century, between 1997, 2000, 2001, 8 out of 10 medications pulled from the market were due to harm to women. 8 out of 10. And one of my very favorites, one of my very favorite examples is the drug Addy. The generic is flimbanserin. The recently approved female, touted as a female Viagra. Addy, I think I'm saying it right. Well, does anyone think that alcohol and sex mix? Right? Well, of course, and they need to study the effects of alcohol on such types of drugs. And the study did happen. It was a small one, 25 participants, 23 men and 2 women studied on a drug intended only for women. I'm not talking 20, 30, 40, 100 years ago.
I just don't understand how these studies pass IRB.
I'm talking about just a few years ago.
Yeah.
Sad, right?
Who's making these decisions? I just don't understand.
I don't understand either. And I see medications being pulled. The big story about the compounding medications. I see good medications with, literally zero documented long-term issues being pulled, or the ability to reach to these medications being pulled that help women and men in a non-gender biased way. I know that's
so Ben, it is very helpful. First of all, since we always talk about root cause medicine on this podcast, I think root cause of the issue here, what what's going on? Is it that not enough women are volunteering, or the people making the decisions kind of steering it more towards men because they secretly believe that's still the gold standard for a 70-kilo man? That, in these studies that are,
And that's
yeah,
why, honestly, that's why I bring up the history of gender bias, because it's important to understand what got us here and how the hierarchy of medical education and of studies got us to this point. I mean, like I said, it was just a few decades ago that we just started allowing women to be fully participating in studies. And as you know, studies take years. And look how long it took for us to get over, and we're still not over it, Women's Health Initiative,
yeah,
right? So it's going to take a lot of effort. And there is, at the end of this, we're going to talk, and when you're ready to wrap it up, I'll give you some very positive things that are happening. But the bottom line is we've got a lot of dogma and a lot of bias to sort through. And we have young female physicians who are still handing out Prozac to the perimenopausal, postmenopausal woman because that's the standard. We still have ignore. I mean, we still think the chest pain, left arm discomfort is the standard for women's cardiovascular disease, acute MI. So got a lot to go through.
yeah, a lot to learn. Like you said, a lot to probably unlearn and rethink these things.
And
Let's go with resources and kind of wrapping up, hopefully on a note of optimism. What's the future of this? How can we get more women in healthcare leadership positions as well? But let's talk about resources first.
yeah, so I pulled some things up so I wouldn't be so random. Give me a second here. Let me find them. Where are we? Here we go. Um, so uh, there's a book, Justice and the Inclusion of Women in Clinical Studies. And by the way, I'm sure within the podcast, you'll have a way for, we can show this. And when I've got a slide, I can show you, I can pass to you, and you can pass it
Sure.
on to
Yeah,
your
that'd be great.
audience. But Justice and the Inclusion of Women in Clinical Studies, a conceptual framework. This was done by NIH, sadly, in 1999, about the issues. We're still in the same place, but about the issues of including women in studies. There's applying a women's health lens to the study of the aging brain. That's another good one, published 2019. Now, the reason why I like this little discussion is because it talks a lot about the gender bias and the physiologic differences and the pharmacokinetics of men and women. There's a physician who beat me to it. She beat me to the book. Alison McGregor. She wrote a book on Sex Matters, discussing gender bias. Wonderful book. So she's a great resource. Caroline Perez, a UK researcher, wrote a book a while back called Invisible Women. Great resource. That's an easy one to remember, Invisible Women. And then the NIH. NIH is coming around. The Office of Research on Women's Health. Wonderful director there. I'm blanking on her name. Oh my gosh, don't tell her I said that. I hope she doesn't watch this. But the Office of Research on Women's Health, they are getting more and more. They've got great conferences, online and in-person conferences on gender bias, women's health. They're really doing a good job pushing women's health forward. Again, a little behind, like all of us are, a little behind on the on research and all that. But I mean, we talked about this. Research is minimal for women's health, but we are growing, and we are getting in a better place.
Well, this is great. Thank you so much, Ben. Thank you so much, Dr. Gonzalez, for coming on today and really shining a light on gender bias and how we can treat our, mothers and wives and daughters and aunts, everyone, a bit better, people that are gender neutral, queer, transgender. I mean, I think there's so many different categories here that we could really get into, but at the end of the day, it's about treating people, as, whole people, individualized, personalized. That people are not numbers. So I really think, you do a great job of that in your practice with your research and education, educating physicians and now the public. Can't wait to read your book that when it comes out as well. Good luck with your book. Can we ask you a couple of...
This year, man, this year.
This year. All right. 2022 is the year. What kind of... We want to ask our guests, too, some fun questions. One question I think would be good. What is your morning routine? We know that morning routines are really great for health. They kind of jumpstart the day, jumpstart metabolism. What is your morning routine? Coffee, yes. Got some.
No, it's not coffee, actually.
Okay. All right.
I've had one cup of coffee my entire life. Isn't that crazy?
That you must be a world record holder for that, I think. Yeah.
I just I don't like the taste of coffee. It's kind of funny, and I'm talking about military, college, medical school.
Yeah.
I'm
not a huge coffee drinker, but yeah, that's funny.
No, I like my tea, so I start off with the tea. My morning routine's pretty basic. I just do kind of some stretching when I get up, followed by I do have a routine. I hang on this straight bar and I do 30 reps of these leg lifts, followed by 3 reps of 30 push-ups. I do that to kind of wake my brain up, wake my body up.
Yeah.
And then depending on the day, I knock out some reading and writing, then head over to the clinic. Breakfast depends on whether I'm fasting or not. So
great.
That's kind of a basic routine.
Yeah, that sounds good. And how can listeners learn more about you and your work with you, your clinic, and maybe learn more about gender bias too, if they'd like?
Yeah, well, I talk about gender bias on my social media and Instagram, for example. You can find me at Ben. It's all one word, Ben Gonzalez, MD, my name. And Gonzalez is with 2 Z's, as my dad used to like to say. We're real Gonzaleses. Now I just got some of the Gonzaleses out there ready to throw rocks at me. So it's Ben Gonzalez, MD. That's my Instagram. So I talk on that subject there, and you can DM me directly on that. And then I guide docs and patients to different resources from there. That's probably the best way to contact me.
Great. Thank you so much, Ben, for being on the podcast today, and we'll talk to you soon. And thank you so much for listening out there. If you find this very helpful, if you found this helpful, please like and subscribe, and share some of this with your friends and family that may not have known about this. So have a great day, everyone. Thank you.
Take care, and thank you.
Thank you for taking the time to listen to us today. If you enjoyed this conversation, please take a moment to leave us a review. It helps our podcast to reach more listeners. Don't forget to subscribe so you don't miss our next episodes and conversations. And thank you so much again for being with us.